Today's topic is anesthesia consideration in OSA surgery. OSA per se as a disease is growing in and out day by day. There are various reasons. And because of this OSA problem is increasing, there are a lot of other things, metabolic issues also increasing in the body. And because of this, now the OSA surgeries are also becoming more and more common. Today's topic I am going to comprise about basic understanding of OSA, drug-induced sleep endoscopy, difficult ventilation issues in these OSA patients, airway gadgets, intraoperative monitoring, difficult intubation, postoperative care. Here, I would like to keep a one disclaimer that I have been associated with Dr. Vikas Agrawal, who is a pioneer in this OSA surgeries in Mumbai, not only in Mumbai, in India. And we have been doing this surgery since last 2004. So a lot of our work comes with a huge amount of done and our practical experience. So not going into the theory, and I am trying to give you the practical insight about surgeries, which is trying to correct the OSA disease. We'll enumerate this one by one in my presentation. Now, as we know, the OSA is a disorder characterized by repetitive collapse of upper airway during the sleep. So when we understand this collapse, it can be a partial, which is hypopnea, or it can be a complete, which is apnea. That reduces the airflow to the lungs. And as a result, hypoxia and hypercapnia develop until the patient arouses from the sleep, at which point the obstruction temporarily ends, and again the same cycle gets. This repetitive nature of events stimulates the sympathetic nervous system, resulting in surge of blood pressure, and moreover, the multiple arousal fragment disturbs the patient's sleep. And as we know, the sleep is most important part of a person's performance day by day. But if we see the sleep fragmentation and this intermittent hypoxia can increase the daytime sleepiness, neurocognitive disorders. And if you see the literatures, there are car accidents are being directly connected with OSA diseases and the people sleeping during their vehicle driving. So OSA is also associated with an increased risk of hypertension. Again, hypertension is there, so stroke, myocardial infarction, sudden cardiac death is bound to be there. So all these things increases. So let us see a little bit of part of the understand the OSA. The cause of upper airway collapse is a complex and multifactorial, and ultimately it results from the interaction between structurally or anatomically vulnerable upper airway and physiological mechanisms who is maintaining the upper airway. Now, upper airway, as we see in the figure also, essentially a tube that starts at the nasal choana and ends at the vocal cord, right? Now, that's what is OSA is a disease of human. This disease is not in other animals. So the descent of the larynx from the skull base down into the neck allowed for the development of complex speech, and also that complex speech allowing process has laid down the groundwork for the development of OSA. So if somebody say that why OSA, it is because of the developmental process for a complex speech, which is specific for the human beings. Nowadays, the most important part of the human functions is becoming a speech. Now, this upper airway, aside from the posterior pharyngeal wall, the upper airway is made up of the muscles with little to no skeletal support. As a result, airway is prone to collapse, right? So if we see this figure, genioglossus muscle is an extrinsic tongue muscle. It is the largest upper airway dilated muscle. Its contraction leads to the tongue protrusion and to the widening of the oropharyngeal airway in the anterior posterior dimension. So the genioglossus muscle, if we see the innervation, innervated by the medial branch of the cranial nerve, that is hypoglossal nerve. And this nerve receives input not only from the sleep-wake center of the brain, but also from the respiratory pattern generator neurons, chemoreceptors, and negative pressures. So in short, all this thing happens, but then during wakefulness, when individuals are awake, the upper airway dilator muscles, particularly the genioglossus muscles, have increased activity during inspiration. And during expiration, again, it is active, but at the decreased level. So the respiratory generating neurons increases muscle activity in proportion to the respiratory drive, and negative airway pressure receptors in the larynx can induces the quick reflex activation of genioglossus muscle. So this is the reason how it is happening. Structure which is determined of OSA. Now, soft tissue structures and skeletal structures are the two major components, right? Soft tissue structures affects the airway size, shape, compliance, and all of which influence the airflow during the sleep. Size and position of the tongue, palate, and tonsil are most important factors in the OSA. Why we are understanding this? Because they are going to operate in this particular structures. The structures determinant of OSA, fat deposition within pharyngeal wall is thought to increase the tissue pressure, leading to the decreased airway volume and increased tendency for an airway to collapse, which is also true. Now, when we suspect any patient in an OSA, So this is about the anatomy or a physiology about the OSA. Now let us see when we get this kind of OSA patient, not only for the OSA surgery, even for any other OSA surgeries. What do we do with an OSA suspected? We always, it's the most important is a stop bank criteria or a calculation or a questionnaires, right? So snoring, tiredness, somebody has observed you stop breathing, high blood pressure, and BMI more than 35, age more than 50, neck circumference more than 40, and gender is male. So male a patient aged 50 with a high neck circumference or a high BMI with history of snoring is immediately goes into the category of OSA. So now if we see the scoring, 0 to 3 is a low risk, but anything more than 4 criteria, it's falling into the high risk. Now these are the oldest, stop bank theory is the oldest theory. Now there are a couple of more criteria has been developed to identify very defined way about the OSA patient. One important thing, PSAP. PSAP here they have included thyromental distance less than 6 centimeter, type 2 diabetes, Malampatti score 3 or 4, and age is reduced to 43 years. So that means now more and more population is falling into the OSA criteria. Now, DISE OSA is difficult airway guidelines get kind of situation where DISE OSA is been included where Malampatti score, because initially stop bank theory doesn't count the Malampatti score. Thyromental distance also they don't count. So otherwise, male, neck gender, and body mass index has been considered. So if we have more than 7 points, then it is a confirmed OSA, which is of the severe category. Now, what are the importance of this? If the influence of different measurement on the ability of PSAP and DISE OSA score detect the severe obstructive sleep apnea, these are the more specific than stop bank theory. And these are the most confirmatory criteria when we see OSA patients. So we should remember this and we'll try to apply not even these patients, even the patients who are not for the OSA surgeries. Now, how does the sleep study report typically looks? Sleep studies report is done in the sleep lab or a machine which is applied during the patient is sleeping in the night. And it majoritarily try to identify the AHI, that is apnea hypopnea index, and the lowest SpO2, which will guide anesthesiologist how this patient is going to behave under anesthesia. So by doing a AHI, if we understand that this AHI is high, we can easily understand that this patient is going to give us a lot of trouble. Now, this is our OT where we do drug-induced sleep endoscopy. So next step of sleep studies, drug-induced sleep endoscopy. There are a lot of variable reports about drug-induced sleep endoscopy. There are variable drugs used for the drug-induced sleep endoscopy. We have started these drugs with the plain propofol when this DISE was introduced in 2008 in our hospital. But we slowly realized that there are a lot of components of we are offering patient a natural sleep. So drug-induced sleep endoscopy, the goal of sleep endoscopy or the idea of sleep endoscopy by drug is to provide a natural sleep pattern to a person. And propofol is not a natural sleep inducer. It is a hypnotic drug. So initially we used to do all the drug-induced sleep endoscopy only on the propofol, and then we realized there were a lot of false positive results also. So right now, drug-induced sleep endoscopy is done with the majority of the drug used is dexmedetomidine, which has got a highest correlation with the natural sleep. This is only drug which gives you a direct correlation with the natural sleep. And this is Dr. Vikas Agrawal, who is sleep endoscopy, and he stands in the front of the patient. So the view is inversely proportional. Now, this is the how we do the drug-induced sleep endoscopy. You just observe the flexible scope is introduced from the nose, and we have reached to the pharynx. And here we are trying to identify pattern of the collapse of the pharyngeal wall, anteroposterior, circumference, or lateral. There are 3 to 4 measurements by which they decide that which type of collapse is there. And we have to do this drug-induced sleep endoscopy with mouth open and with mouth closed. So drug-induced sleep endoscopy is typically to be done under the guidance of BIS score. Ideal BIS score is between 70 to 75 is identified, and we try to reach over there. So I will tell you how the drug-induced sleep endoscopy happens. Drug-induced sleep endoscopy, we typically take the patient inside. We take the IV line, give 1 dose of injection glycopyrrolate IV, and 1 dose of injection midazolam 1 milligram. This will reduce the secretions, and this will start reducing the anxiety of the patient. And we then slowly start the dexmedetomidine injection. Dexmedetomidine injection can be given in the 2 way, either slow dose bolus or in a slow IV infusion. We do both the methods, but we prefer slow intermittent bolus doses, that is 2.5 microgram in intermittent doses, and generally we required 0.5 to 0.7 microgram per kg. So that is around 30 to 40 microgram in a 80, 90 kg patient. And in a more than 100 kg patient also, we have never seen the requirement going beyond 50 microgram. And if patient is not sleeping with this, after 7 or 8 minutes, we give 10 milligram of propofol to add to the sedation of the patient. So here are the two important points: slow infusion, lot of patients, 15 minutes for the act, and then do sleep endoscopy with the nose preparation so patient doesn't sneeze during the process. The endpoint of drug-induced sleep endoscopy is apnea or in a low saturation, which is dangerous, or a patient the BIS having a 70 to 75. Any of these three happens, that is the endpoint of the drug-induced sleep endoscopy. And the findings will be noted or recorded by starting from the nose, nasal cavity patency, and nasopharynx, and the pharyngeal wall, as well as the base of the tongue. Some people having a large lymphoid tongue, which will fall and block the vocal cords and the airflow. So these are the certain things which we diagnose. The importance of drug-induced sleep endoscopy for anesthetics is, while doing this, we can also judge how difficult is going to be our ventilation as well as intubation. So this is a dynamic study of an airway kind of thing, right? So if we want to see now more, then this is also again, this is a nasal cavity having a lot of turbinates, and this we are going inside, and this is, we are entering into the nasopharynx, and this is the pharyngeal wall. This is the nasopharynx, and see the movement of the nasopharynx, and this is the inverted view, right? So vocal cords anterior posterior is inverted. And this is how we have a circular collapse from the pharyngeal wall when the patient is sleeping. So while this is happening, patient having a complete apnea. There are a lot of other methods, which is called MRI, which will generally study the volume of the tongue. And over a period of time, volume of the tongue is increasing. That is also another reason why the OSA is increasing in the population. So a lot of studies have been seen, and then we have concluded after a lot of studies are there. So the severe OSA patient with more lateral pharyngeal wall collapse as compared to BMI matched mild OSA patient. So if you compare mild to severe, the lateral wall collapse is more common into this, but otherwise all varieties have been seen and all varieties have to be treated. Now, most important part over here is a decision making to do nose surgery and upper palatal surgeries, UPPP together or as separate. So here there is a lot of things depends upon the surgeon's expertise, surgeon's confidence, anesthetist experience and anesthetist confidence, as well as the DISE finding. If severe nose problem and the complete circular collapse from the palate, we generally try to do in a separate stage surgeries. But if both are moderate, we are now trained to do both in a single sitting, because after the surgery, nose is going to be blocked completely, as well as throat is also operated. So patient will have a lot of difficulty in extubation. So once DISE is done, now we understand that OSA will give you a lot of difficult intubation is the later on part, but a lot of difficult ventilation. Here the question is start with the negating the difficult ventilation part. So apart from our routine measures, we have two important points, that is thrive and ventilation with the LMA as in a technique, as in an elective technique for this. Those who have seen the Thrive, there is a beautiful device. I would say that this is humidified oxygen given, humidified high flow oxygen given via nose in a most comfortable manner is this device. And sometimes I feel that this is such a beautiful device that we should be having it for all the intubation, because it will not allow patient to become hypoxic during our difficult ventilation intubation process. It will allow us to give a little longer period of time to maneuver the difficult ventilation and intubation time. So one is a Thrive, where we generally keep a flow of 30 to 40 liters per minute, which is very well tolerated even in an awake patient. Other important part, double hand ventilation with somebody squeezing the bag or directly putting in LMA. Give the sedation to the patient or a propofol, put in LMA, ventilate the patient, and then you start muscle relaxant, and then you try to intubate the patient. Now here one more thing is there, that even the position for an OSA patient, as we do it for all bariatric patients, is very, very important. Now, what is the most important point which I try to highlight to everyone over here is quick intubation. Now, why do we want to have a quick intubation method? To reduce the ventilation time, because the jaw is heavy and hand gets tired if we want to ventilate for more than 1.5 to 2 minutes. So choline has a proper role. If you anticipate a difficult intubation ventilation process, no doubt choline has a proper role. But with the entry of Sugamadex, now we have moved to the rocuronium. We have enough stock of Sugamadex and kept ready on the trolley. So with our assistant trained to do that, and then we do quick rocuronium intubation with the Sugamadex ready if we require to reverse the patient. I have gone through all the articles and everywhere that both are equally good, scoline or a rocuronium with Sugamadex reversal in case of an emergency situation, only and only if you are prepared very well for it. So we made our team prepared for it, and now we are using rocuronium, and Sugamadex, if required, is available in sufficient quantity. Now the question comes, if you negate yourself from a difficult ventilation, again, two-hand ventilation, simple airway, or in a nasal airway, if the nasal cavity is allowed to be accessed by the surgeon, so you put a nasal airway and ventilate. If not, then you intubate the patient or with the LMA first and ventilate the patient and then try intubation. Or you have a thrive. All these methods are done, and if you are able to ventilate very nicely with either choline or with the rocuronium, the important part comes with difficult intubation. Again, here the role of VL scope comes because we want to have a quick intubation. Why we want to have a quick intubation? Because generally this patient loses the oxygenation very fast. So unless and until you have a device like Thrive, they start desaturating a little early if they are obese and having issues with the lungs. So in difficult intubation in our unit, our protocol for all this kind of difficult intubation is video laryngoscopy as in a first shot. First shot has to be the best shot because we don't want to waste time in doing a regular scopy and then unsuccessful attempt, and then again ventilate the patient, then again do the video laryngoscopy and do the intubation. So first shot is the best shot. So take video laryngoscope. Having enough experience in a video laryngoscopy intubation, every member of the team has been taught 50 times normal patient intubated with this and with video laryngoscopy, and then they are allowed to intubate. So proper learning curve, and then intubate every patient with a video laryngoscopy. So your number of attempts reduces, injury to the internal structures reduces, which is absolutely not acceptable by the surgeons, and no hypoxia, no tachycardia, no hypertension, or no repeated choline attempts. So first shot, best shot, even all the journals are coming up with these ideas that yes, use first shot, best shot, video laryngoscopy intubation, master the skill and use it all the time. Coblation adenoid removal. Now, this is the surgery which is common even in an adult patient where the adenoids are very large and blocking the nasal airway. So here this coblation adenoidectomy is happening where the kind of a little amount of fluid is continuously running to the coblation device, and that is trickling to the throat, which we are able to take care with the throat pack very easily. So what they do for the palate, there are a lot of different surgery. This is one of the oldest surgery, uvulopalatoplasty. Nowadays, this is also becoming less common, and pharyngeal suspension technique is becoming more common. But still, in some cases, uvulopalatoplasty is needed, or in multiple things are needed in a palate. So if you want to see, this is the surgery by which this is the pharynx part where the tonsils are removed, and now the suspension bridge sutures have been taken, and uvula is also cut, and then they will drag the palate. They will drag the palate and suture the palate, so palate is not coming in between the airflow during the sleep, and that's why the patient will have a easy ventilation. And this is the part where Dr. Vikas is right now operating at the tongue base. See, you can see the tube over here, and this is the part where so it is absolutely near your tube, and it is absolutely vascular area and the base of the tongue. The moment you extubate this patient will definitely have a lot of difficulty in breathing, and that's why the extubation becomes extremely challenging. This place becomes sometimes really bleeds also. So this is very, very sensitive area where the surgeon is operating, and our tube is next to it, and next to that we have vocal cords. You can imagine if this thing starts bleeding post-operatively when you have extubated the patient, and then management is really, really very challenging. Thanks to the lot of new devices which are giving a good hemostasis, and that's why the hemostasis becomes really great. So we have not seen many cases of bleeding post-operatively, but we have seen one secondary bleeding from the tongue base post-operatively, the patient came after 7 days to the OPD with the bleeding, and we had to take that patient for any emergency surgery. This is how lymphoid tongue been taken care of surgically. Again, a coblation, and they create a fibrosis, so tongue volume becomes less, and then they reduces the chances of collapse during the sleep. I hope everybody is getting the proper view of this tongue-based surgery. Now, this tongue-based surgery is the most difficult part of the surgery for the OSA surgeries. Right? So now when all this thing is happening, what are our role as an anesthetist? Apart from, as per the other general anesthesia, here the depth of anesthesia becomes most important. So our unit use this, which is by the Covidian company, which we are using it for each and every patient, because we have seen a variable requirement in such kind of the patient. Some patient requirements are really very low, or some patient requirements are really very high. Two drugs we have using both the drug. One is sevoflurane, one is desflurane. I really love to have a desflurane for such kind of obese patient, very fast recovery. All the airway reflexes have been studied between the sevoflurane and desflurane, and desflurane always score more when you study the reflexes immediately after extubation. No doubt, after 15 minutes, the recovery period probably both having the same. But if you study the airway reflexes immediately after desflurane, it is the best. And there are climate change related things is always been told, but I would say that a lot of our other pollutant in the current scenario are more dangerous than the desflurane. But it's my personal opinion. But I do use desflurane in certain situations. Propofol infusion, the sevoflurane, I have only one major problem, that is an emergency reaction. And these patients are very difficult to handle if they have emergency reaction of sevoflurane. So we generally use this guided propofol infusion at the last of the surgery, last 30 minutes of the surgery. And we try to avoid this sevoflurane related emergency reaction. Obviously, all these obese patients, we don't use opioids. If they are thin OSA patients, we use short-acting opioids like fentanyl and remifentanil. Remifentanil is definitely scores more. Remifentanil infusion is a fantastic drug. But otherwise, we avoid any long-acting opioids or a multiple doses of opioids for this 2-hour surgery. Now, we can compare this impact of Sugamadex versus neostigmine. Now, the reversal on post-operative recovery time in a patient with obstructive sleep apnea undergoing bariatric surgery. Double-blinded randomized study has been done. Actually, there is no difference between Sugamadex versus neostigmine. There is no difference as such. But I tell you my personal experience. The confidence of Sugamadex reversal by seeing the patient's recovery is much more than the neostigmine. But the downside is patient comes out very rapidly. So when they comes out, there is a possibility that they will cough on your tube. And that is the time there is a possibility of a bleeding from the surgical side. So somebody has to learn the Sugamadex again. And like neostigmine we are learning, and Sugamadex using in this kind of patient with the oral surgeries. Now, extubation and hemodynamics. Tachycardia and hypertension is very common during the extubation because all these patients are generally hypertensive. So during intraoperatively, we try to manage this with dexmedetomidine as well as magnesium sulfate to manage this hemodynamics. And so we need to plan extubation well. And dexmedetomidine becomes very, very useful to me. And in case required, we use beta blocker and NTG ready to reduce the hypertensive response during the extubation of these patients. Difficult extubation protocol, as per our standard protocol, airway extend bougie, extubation on LMA is not possible here because they have operated on the palate. So surgeon will not allow. Nose is packed. Surgeon, we have no nose passage available, ready for reintubation, ready for tracheostomy. So the mark of tracheostomy site from the beginning. So you are not trying to surge the cricothyroid membrane. And we have this all the equipment ready. Luckily, this surgery done by ENT surgeons, so they are expert in doing a tracheostomy. So we plan our extubation, and entire team is informed about the extubation criteria. And whenever we are preparing extubation, there are enough help is first important point. There has to be enough help. There has to be a perfect plan for an extubation. Surgeon is still around. Surgeon is not allowed to go out of the hospital or out of the OT complex. They are there in the OT complex, and you have a reasonably good help from the OT technician or anesthesia technicians also. So we decide whether to extubate or not to extubate. If extensive surgery on the tongue with an obese patient, we do not extubate. If in a reasonably moderately OSA patient with a nose and throat both, we really extubate on the table and they really do in trouble if our extubation is awake. Here, role of deep extubation is not there. So awake extubation is the most important part. And if tracheostomy is needed or tracheostomy is done, then the question of this is not there. Airway emergencies, post-extubation bleeding and management. So we need a fully awake patient. Your fully awake patient will give you a lot of hemodynamic instability. So as I said, we manage hemodynamic instability with other drug like desflurane, magnesium sulfate, beta blocker, and anti or extubation on a bougie. Now, once we extubate the patient with head up position is done, 45-degree head up is done, and these are the type of the devices BiPAP. Generally, these CPAP BiPAPs are being used by the patient previously. They know how to use it. They are using, generally they have a machines. So we ask that machine to be there. And if surgeon is confident, surgeon will have to ask surgeon whether we can use it because that forced air should not create a problem to the surgical site. But my surgeon is allowing me to use if it is a needed. So we use it. Nose is blocked, but if the nose is open, say for example, they have done only palate surgery. So under guidance, we put a nasal airway during extubation. We keep the nasal airway for half an hour or 45 minutes. Or if nasal airway is also out, then we have a chance that we can put a nasal CPAP only. So it does not disturb the palate related surgical part. So nasal CPAP is also a good idea if the nasal passage is open and nasal passage is not operated. This Vigon company has this mask, which is called CPAP mask. And this CPAP mask has this device here, which generates 8 to 10 millimeter of H2O of CPAP in an open system. So this is very well tolerated mask in a post-operative patient. And this CPAP will allow patient to breathe better. And for the patient, and this is very good, it will give a comfortable 8 to 10 millimeter of Hg CPAP to the patient post-operatively continuously. So that will allow patients to have some kind of a PEEP post-operatively, and you have a good ventilation and good help into the ventilation to the patient. Post-operative airway edema, hemorrhage, and respiratory complications are a concern, and the patient should be recovered in a monitored setting until they return to their baseline. So these are the concerns. So one assistant ENT surgeon is always there for 30 minutes. One anesthetist is always there in 30 minutes for post-operative care of the patient. Post-operative care, all airway equipments are ready in case of any bleeding or any emergency and for any other complications. And post-operatively, we give a Vidocort inhalation, that is a nebulization post-operatively to reduce the airway edema. And regular analgesics are enough to manage the patient. I think this is very, very good if you are not snoring during my talk. Thank you so much.